Okay, so we're done with the acute care. So as already mentioned, the patient survives the first 24 to 48 hours. So we maintain CPP. The patient will now enter the rehab phase. As far as medications, again, they're discharged on we'd already discussed the 8 stroke core measures. What are they again? Antithrombotic therapy evaluated on hospital day 2, right? Hospital day 2, meaning 24 hours after. Right. If it was ischemic stroke, then they received thrombolytics, right? Stroke education, and then smoking cessation, yeah. And then we had statin therapy. Who's put on anticoagulants again? AFib, A-flutter must be put on anticoagulants. What's 7 and 8?
PT.
Didn't we already mention that?
No.
No? Okay, assess for rehab. And what's the last one?
The LDL section. No, that's the statin. Or is that different from the statin? The LDL monitor?
I just refer to the list, okay? So you can go online, look at the list, go under Joint Commission. So make sure you type in Joint Commission, JCAHO, and you search for the core measures. So here are the rest of this will start inpatient. Okay, this is before the patient is even discharged from the hospital. So we already begin. The PTOT will already start working with the patient, teaching them how to work, ADLs with their current deficits. So whatever limitations they have, the PT and the OT will teach them how to maximize what sensory motor function they have based on their limitations. Okay, so brushing their teeth, dressing, for instance, getting up, walking to the bathroom, doing the paperwork, everything. Chart 62-3 are quick reference, okay, quick short references for self-care, ADLs. Now, these eating devices are quite costly, okay? They can range from a few $100s to $1,000, okay, if they buy the complete set. Okay, these are just the kitchen, the feeding adaptive devices, especially shaped spoons, plate guards, cups, okay, especially made cups, assistive devices, okay, again, tailored to their specific limitations. Raised toilet seat, because most of these patients have mobility problems. So how can they get up if they're so far down and at a 90-degree or higher angle, hip flexion? It's hard to get back up. There will be therapy. By therapy, I mean group therapy. Okay, so for stroke survivors, there's one in every community. Every city has one. They usually involve the significant others because it's not just the patient adjusting to this change. So let's say it was, who are you in your family, Sam? You a breadwinner or you just yourself? Okay. So how would your stroke affect your family? So there's nobody that cares?
Financial wise.
Okay. Well, he'll qualify for disability. Yeah, he can apply for Medicaid. He won't be left on the street, right? So do we want to have a stroke?
No.
Okay, do we wish this on anybody? Okay, that's just what I'm trying to get. Okay, so a life-changing event changes a person's life, not only that person, but their loved ones as well. What about your work?
Oh.
Don't worry about them. They'll replace you in a couple weeks. Okay. Yeah, they'll replace you right away. They'll say, of course, they'll probably get a collection, and then send you some help. But that's it. Okay. The company, the hospital has to move on. Okay. They have to keep operating. Okay. They'll have, they'll have pictures of you, but that's it. So weigh your priorities well. Okay. So family, loved ones first. All right. As your boss will replace you very soon. Let's look at now the adaptations with the vision loss. Remember the hemianopsia? So there's no table for this one. You're gonna have to read the paragraph about how to compensate. So let's say they have left homonymous hemianopsia. That means the left half of each of my eye is blind. So when I'm looking here, can I see Katerina? I'll see a little bit of Zini. I cannot see Katerina. I'll see Alicia over there. When I look here, okay, maybe I'll see Katerina now. Okay, oh, there's Katerina. Okay. So is it dangerous when I move around? Yes. Okay, so I'll have plenty of blind spots, basically, right? Can I drive? Not good. Okay, I will lose my license. Okay, I can't drive anymore. This also applies for the significant other, including the caregivers, which is us. So how do you approach the patient? They have left homonymous hemianopsia.
The right side.
The good side. Always announce your presence when you enter the room. Okay, knock, hey, I'm here. Okay, who you are. With nutrition, especially if there's swallowing difficulties, make sure you thicken the liquids. There will be recommendations by the speech language pathologist, whether it's honey, puree, or whatever thickness. Okay, there's different levels of thickness for liquids. Whenever you see signs of drooling, let's say, so that indicates difficulty swallowing, yeah? So it's usually drooling on the affected side. So if there's left side paralysis or weakness, the drooling will be on that side. So where do you put the food? On the right side. Okay. Most patients, though, if you look at statistics, patients after a stroke suffer aspiration pneumonia within the first 3 months after the stroke. They'll be readmitted to the hospital. Okay, it's very common. Right. So plus the family is new, or let's say the patient is new to the consistency of the food now. So it takes a lot of getting used to. Okay, so most of them, again, statistics wise, nationwide, many of them get readmitted for aspiration pneumonia within the first 3 months after a stroke. If they continue to have those problems, usually the doctors will recommend a feeding tube. There'll be NPO for safety. Okay, they'll just have a feeding tube. For bladder and bowel control, so this can range between the patient may have, depending again which part of the brain was affected. So they can either have incontinence, bowel and bladder incontinence, or bowel and bladder inability to empty the bowel and bladder. So they have constipation or urinary retention. Can go both ways. Thought processes. So the patient will have rehab also on a cognitive level. There will be neuro activities for these patients to rehab, their brain function. That's all under the most nursing homes and rehab facilities have programs like these. I haven't heard any for the home. Okay? It's only in inpatient rehab. Let's go to communication now. So we have a chart. However, there are also details that I grab questions from under these paragraphs here. But the communication chart is 62-4. So this is how you communicate with patients with aphasia. They didn't really specify whether it's expressive or receptive. They kind of just jumbled these strategies. So I copied and pasted some of these, changed a few words, right, on the exam. Which one? Okay, turning, because again, mobility is impaired. And DVT precautions as well. Okay, sexual dysfunction. These patients will have to take a less active role. Okay, they can still have sex, but modifications will have to be made, and expectations must be tempered. Okay, so it's not always that the partner may want sex today, but maybe the patient's mood is not conducive today. Okay, so again, open communication is necessary for these. We have several patients that are getting younger and younger. Okay, we're getting stroke patients at 35, 40, right? In their 50s. I just heard, yes, one of my classmates I went to high school and college with, and they're twins. So one twin had a stroke last year in California. He's older than me, so he's probably in his 50s already. He's 2 years older, but and we're still about the same age. Okay, so he had a stroke. We're close because his wife has and me have the same birthday. Okay, so that's about it for stroke. You know what? It's only 30 minutes, so I'll